So please keep your questions at the end of this session. We'll have 3 more talks, and then we'll have a panel session with questions and discussions. It was an amazing talk by Dr. Nigbakar. We're going to move on to our next speaker, Dr. Elsie Koh, who is exceptionally not a nephrologist here. Actually, in fact, the rest of the sessions include 2 colleagues who are not nephrologists, who are experts in their field. Dr. Koh is an interventional radiologist, and she has been known and recognized for her expertise, among others, in the vascular field. We nephrologists in the field of nephrology, you are very much dependent on vascular colleagues, vascular surgeons and vascular radiologists and intervention radiologists. So she's the former medical director, chief medical informatic officer, regional medical officer, medical advisor board member at Azura Vascular Care, and she has had a large number of acknowledgments and awards for being an excellent physician. I don't know, Dr. Koh, are you here? Well, actually, yes. So please join me to welcome Dr. Koh. Thank you very much. Thank you.
Hi, thank you so much, Peter, for inviting me. I'm very happy to be here for the first time. I'm very impressed with this conference, and the nurses, I spoke yesterday, and that was incredible. They're very engaged, so kudos to you. Thank you so much. I'm going to be talking about aneurysms, and this came about because of a huge concern. I'm sure each and every one of you have heard of a patient, or maybe you have a patient who had significant bleeding from a ruptured aneurysm. And so this topic came up as something that we need to really focus on, and telling our dialysis staff who see the patients every day, when should you advise the patient or send the patient to a vascular expert. So these are my disclosures. And I want to acknowledge the slides came from Dr. Murat Sor. He's the Chief Medical Officer at Azura. And Dr. Burgess is the person we worked with to get the staging system. But it's been a collaborative effort that's been evolving. And so we actually changed to 7 stages of aneurysms to 4 stages with RRI. So these are the questions that I'm going to give you. At the end, we're going to review the answers, but I just want to show it to you. Which one of these aneurysms is really, really bad? Okay? And the clue is the most important factor is the quality of the overlying skin. That's how you're going to know, and that's what we're going to talk about. Which one is the most worrisome to you? We're also going to look at this question is, what's the best way to save a patient's life from bleeding at home? What is the key thing that you're going to tell this patient that's going to save their life? Okay, and we're going to go over that at the end. So an overview is we're going to talk about the common causes of aneurysms, the staging system that we came up on purpose for the use of artificial intelligence that is being developed by RRI in conjunction with the FMC business intelligence team. And I think Hanji is here, Hanji Zhang has been leading that, Hanji. And we are going to talk about all the, how to stop the bleeding. And once it stops, what do you do next? When do you send the patient to the vascular expert? So, some facts about aneurysms. So the fact is that the incidence is all over the place. It could be 5% over 60%, depending on the article that you read, and for fistulas and grafts. And the incidence is higher in proximal axes than the distal ones, and it just has to do with the hemodynamics of how the fistula will drain and what obstruction it could come up against in the flow. It's usually in the cephalic vein more than the basilic vein in fistulas. And what's the difference between a pseudoaneurysm and an aneurysm? So pseudoaneurysm is basically, it's more common in grafts, and if you can visualize, it's like a contained rupture, okay? It doesn't have all the walls of a true aneurysm, and it's often related to surgical technique, from a procedure, from needle punctures, vessel rupture, also related to infection. A true aneurysm has all three walls of the blood vessel, the adventitia, the media, the intima, and it's often difficult to define because fistulas are enlarged as it is over time. And true, so basically dilatation of more than 3 times the native vessel diameter. So here's a true aneurysm, and often it's exacerbated not only by high blood pressure, the patient has malignant hypertension, or it could be by an outflow issue. So if it's draining, and as an interventionalist, we see this all the time, where there's a stenosis where it drains, and because of that, it's back, all the flow is backed up. You see it pulsating, and over time, it grows sideways, or it grows in a tortuous fashion, longitudinally. So there's no room, it becomes very tortuous. It could be caused by repeated access. And also treating these outflow stenosis is vitally important in reducing the growth of these aneurysms. And that's why we like to see patients often with aneurysms on a routine basis to angioplasty, the outflow stenosis that often recurs. The most feared consequence, obviously, is rupture of the aneurysm. So these are the kind of the indications when you need to start thinking, maybe I should send this patient to somebody. So if the patient has pain, if there's change in the skin turgor, there's a discoloration, if there's a scab or ulcer formation, and often many of us see that, there's a rapid increase in the size of the aneurysm, if there's infection, if there's spontaneous bleeding episodes and patients telling you, I'm bleeding at home, I had to hold pressure, those are indications. So let's talk about the staging system now. So there's 4 stages, like I said, 0, 1, 2, 3. Okay, 0 is basically no aneurysm, no action required, no scabs, no pain, no necrotic area, no aneurysm, no erythema, a normal bruit and thrill, that's very important. Okay, and then when you lift the patient's arm, everything drains, so everything flattens out. The aneurysms flatten. If I'm saying the fistula drains, so there's no outflow stenosis. Now, if you have aneurysms and the skin looks normal, this is very important. You lift the patient's arm up and the bumps just go down. They're soft to palpation. You can feel a thrill. There's no thinning of the skin. There's no whitish discoloration that we see often when the aneurysm is growing faster than the skin can recover, so the melanin doesn't grow. All those things, it's basically normal except the fact that they're bumps. Okay? So 2 is where you should refer someone to a vascular expert. So you're going to see that there is some whitish discoloration, there's some thinning of the skin. You're going to see any of these following. The patient has some discomfort, it's pulsatile, there's the shiny skin look. You listen further up on where it drains on the venous side, and there's like a sound, a whistling sound, and this is usually a sign that there's a significant stenosis. So if you see that the fistula is bounding, boom, 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 and then further up, you feel up, and there's if you can picture water going through a pipe, and it's coming up against the naring, it's going boom, 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 it can't get through, but on the other side, it's spraying out, that's the stenosis. So that's what you feel. So, and then a lot of times there could be bleeding around the needle sites. There can be some bleeding beyond, the patient has to stay longer than usual, and there's some erythema along the axis. That's when you should escalate, tell the patient what to do, and we're going to talk about this later, what to do in case there's any bleeding at home. And you're going to review their antiplatelet and anticoagulation. You're going to swab any areas that might be erythematous that you might be worried about infection. You're going to lift the arm up and see it drain. Now, this is the most worrisome, and there's the picture, right? Score 3. This is where you shouldn't needle the patient. You should urgently refer the patient to the vascular team that you've developed some kind of rapport with. So whether that's the emergency room because of the vascular surgeons in the hospital, or it's an access center that you've developed rapport with, and you know that person's going to take charge of this patient. If it's after hours, obviously it's the ER, but sometimes we've seen patients go to the ER and they just get sent home with a stitch. So it's really important to develop rapport and know who that vascular expert is. Okay, so I'm loosely defining it here. You're going to keep the patient in the department until you know where the patient's going to go. and you're going to take all the other previous actions that we talked about. So this is where you see the patient has pain and swelling. The patient reports maybe bleeding at home. There's scabs greater than 3 millimeters. It's just pulsatile. You don't feel that thrill. It doesn't drain when you lift the arm up. And there could be some oozing and pus. And it's just not looking healthy here. Okay? So, what are the common causes of dialysis access bleeding? So it could be bleeding from areas of skin thinning from frequent cannulation. And those whitish discoloration can be from previous punctures, but it also could just be from the growth of the fistula just way too fast and the skin cannot recover, okay? So the point is, and a lot of you already know this, is that to rotate the needles more than a 1/4 of an inch away from the previous site, use the whole length of the access, try not to cannulate the aneurysm. Sometimes you can't avoid that, and you basically cannulate in the areas where the skin is healthier. So I want to show you what it looks like to have a stenosis just beyond the aneurysms, and you can see the purple arrow is where there's a severe stenosis, and we see this very often, where the patient has a recurrent stenosis, let's say 3 to 4 months, and it becomes pulsatile. You could feel that thrill, the bruit, right at the area of the stenosis, because like I said, it's spraying out. And this is where we can really help the patients. The bleeding stops. You have so much better dialysis, and you have more peace of mind that this aneurysm is not growing out of control. So we will balloon that area. How do you stop the bleeding? So this is where it's very important. You don't want to, how many times have I heard of a patient, they wrapped this towel around their arm at home and they were holding pressure, but they weren't holding pinpoint pressure. Pinpoint pressure is vitally important. So single finger at the bleeding site. You could also hold pressure if there's another person, to hold pressure in the inflow. So you're going to teach them, you're going to hold pressure right where near the anastomosis and hold pressure there. This may, and don't peek, because then we'll keep looking. And the other thing that people often do and was taught in the KDOKI guidelines is to put a tourniquet higher up. However, you have to keep in mind if the patient has malignant hypertension, even that tourniquet's not going to do anything. And so you have to be really careful about that, because you're basically closing off the flow to all the veins, the venous outflow. You're still maintaining flow in the artery, so it's just going to exacerbate the bleeding. You're not going to be able to control it. So you have to, that will work if the patient's blood pressure is not over 200. So the role of a vascular expert is basically endovascular or surgical, okay? So let's just talk. Endovascular angioplasty, we could put a stent or a stent graft, a stent in the outflow, or stent graft across a pseudoaneurysm or the aneurysm itself to exclude it. And we could do inflow banding, like the Miller banding procedure, which is basically closing off the blood flow to the access, restricting blood flow, like creating a dam so that less blood goes into the fistula. So like I showed you the before and after the angioplasty, that's what it looks like, and suddenly the aneurysms are much softer to palpation. That's what I see when I angioplasty. I make sure it's softer to palpation, it feels better, it's different, and I might look under ultrasound to make sure it really didn't, because this is just a 2D image of contrast in the patient's arm. And sometimes there's more, the narrowing is actually worse. So we have to go by all of that, what we see, what we feel, what we hear. Here's a pseudoaneurysm, and we can put a stent graft. So a stent that has a jacket on it, a Gore-Tex jacket. So it basically excludes that pseudoaneurysm. That's something we can do for the patient. I have had that done. Patient had a rupture, contained rupture at dialysis. They had the swelling. They wanted me to check it out. I did an ultrasound in the pre-op area. I noticed that there was this pulsating aneurysm, and there was swelling. There was edema in the subcutaneous tissues. So what I did is I put a stent graft, and then I told the dialysis center, do not puncture in this area for 2 to 3 weeks. Avoid this area. If there's no other place to put, then I have to put a catheter in, because if you're going to puncture through that stent graft, it's going to just start creating another path for the pseudoaneurysm to come out. So once it stopped, what to do next for dialysis access bleeding. So one of the other things, okay, beyond the stents and the angioplasty, is the inflow banding. You often see patients, the patient has an ulcer in their finger because of Steele syndrome. And Steele syndrome is an imbalance between the hand getting enough blood and the fistula getting enough blood, because it's the same blood supply. And what we're doing with inflow banding is we're creating a stenosis, man-made stenosis in the arterial limb of the fistula, and allowing more blood to go to the hand and less blood into the fistula, and decreasing that pressure in that fistula that's aneurysmal. So here is a fluoroscopic depiction. You can see the elbow on the top. Down, you can see some coils in the forearm. And there's a wire across the AV anastomosis into the brachial artery. And what we're doing is we're putting a balloon, and usually it's anywhere from a 3 or 3.5 or 4 millimeter balloon in the arterial limb. Okay, and we're cutting down, and we're basically tying a suture down to that inflated balloon. So now I have a precise stricture of whatever size that balloon was, a precise stricture, and this is the Miller banding procedure that will allow that banding to happen endovascularly. So here is a suture that's being pulled in underneath the fistula in the arterial limb. We also dissect above it, and then we tie it, cinch it down to that inflated balloon. And now you can see before and after. In the arteriogram, you see the tip of the catheters in the brachial artery on the 1 o'clock position. We're injecting dye, and you can see more blood, more arteries are being filled in the forearm compared to the before picture. And so you can see the stricture that's in the fistula right before the aneurysm. That's the Miller band that was created. We can also do surgical repair. Vascular surgeons mostly do this. Some interventionalists are very brave and do this, but I've done this sometimes, but I'm not very comfortable doing this to this extent. So they can cut the aneurysm and repair. This is pre-reduction and post-reduction. Okay, so what are the things that you might hear as a clue that the patient's going to have a ruptured aneurysm? So I picked a scab on my access last night, and it bled for 2 hours. I had to go to the emergency room over the weekend because my access wouldn't stop bleeding. My arm feels tight, like it's under pressure. When I removed my bandages from dialysis the day before, it was still bleeding and oozing. So, aneurysms and ulcers pose a high risk for bleeding. They often result from a mismatch between the inflow and the outflow, which can be treated with angioplasty, stenting, inflow banding, and continued education of the dialysis staff is needed to avoid delays for definitive treatment before this happens. And I can't wait to see what your team does with the artificial intelligence, Hanji and Peter, because that's going to be amazing. This is a different talk, but they're looking to use artificial intelligence in order to help the dialysis staff determine when an aneurysm needs to be looked at immediately. And that's it. Thank you. Oh, yeah. I'm sorry. I don't know why it's not advancing.
So since we finished a little bit ahead of time, we have time for 1 or 2 questions, but again...
Oh, no, the questions... I'm sorry. So when we go back to the questions that I brought in the beginning, so what is the most... of course, the answer's already on there. You're supposed to answer. But you know that number 4, okay, more than number 5, is the most worrisome. And why is that? You could see the bleeding, that's kind of the oozing around the crater, and it's elevated. And the person put a tourniquet up in the armpit area. That kind of concerns me, because if the patient's blood pressure is really high, this can cause the patient to have a rupture. So you got to be really careful about putting that tourniquet. The second question, the best way to save a patient's life from bleeding at home. And exactly, teaching the patient the proper technique. holding pinpoint pressure over that bleeding site. So even if it's not aneurysmal, if they bleed from a previous cannulation zone, you're going to teach each and every patient how to hold pressure. Thank you.
So, if I may ask Dr. Koh for one burning question. So, since I just felt after practicing 20 years, now I have to question what I did for the past 20 years of placing tourniquet on that arm. And I feel that I'm not the only nephrologist here who should admit that sin. That's what we did actually. It's quite interesting that this is widely practiced in most, if not all, dialysis units. We have 7,000 dialysis units in the United States. That's what we do because we're desperate when we see bleeding patient is not, bleeding doesn't stop. So, and I agree with you that at the same time, we tell the patients, please keep placing the pressure, right? So should we really go now to tell our dialysis nurses and technicians in different dialysis centers that this should not be practiced anymore?
So I think it depends. That's the answer. I think if the patient doesn't have a pressure that's 220 over 100, and because I've seen a patient bleed all into their chest and back, and I mean horrible. You have to be really careful to know that, if you're putting the tourniquet on and it's bleeding more, obviously the tourniquet's not working. So yeah, I think that's a really tough question to tell. Like, I can't tell them not to do that because it works in some situations. So.
Great. With that, again, we're going to appreciate Dr. Koh. Thank you very much.
Thank you.